Hello, everyone, and welcome to the Essential Substance Abuse Skills webinar series. I'm Kate Trams, and today we have invited Sean Baer to speak on clinical evaluation screening. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Please check out our other upcoming webinars in this series, as well as our American Indian and Alaska Native Behavioral Health series, which takes place on the first Wednesday of each month. We always welcome suggestions of topics or speakers, so feel free to make suggestions either in the Q&A pod or by contacting me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and CEHs are available on request for a $15 fee. A request form is available for download in the Files pod in the webinar screen, and I will also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so if you have questions about the presentation or about the Adobe Connect system, please use the Q&A pod by typing them in the field at the bottom. We will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Sean Baer. Sean earned his BA from Una Vista University in 2002, majoring in psychology and human services. He also studied mental health counseling at Drake University for 2 years and is currently working on his master's degree. He's a member of the Meskwaki tribe in Tama, Iowa, and has worked with Native Americans in substance abuse for many years. He is also an Army veteran of 9 years and discharged from the 82nd Airborne. His passion is to assist people in overcoming their substance use issues, as well as other issues, and to return to the spiritual ways of their ancestors. So we're excited to welcome Sean and have him present on clinical evaluation and screening today. So with that, I will pass things over to you, Sean. Thanks so much.
All right, thank you, Kate. Hello, everybody. Again, my name is Sean Baer. I work for the National American Indian Alaska Native ATTC. I'm a behavioral health consultant here. So we'll get going into this. Remember that this presentation focuses on the screening process for alcohol and drug abuse clients. The first step is to, in the process, determine whether the client recognizes the need for change in his or her behavior. The next step is to interview the client to determine whether he or she describes behaviors that are predictive of alcohol or drug abuse, and then ask specific questions. But anyway, remembering that with the first step here and looking at the screening process, you need to remember that not all clients or patients will move on to the evaluation. This is something also for seeing whether there is a problem that needs further evaluation, or that they can also be discharged at this time. Okay, looking at the clinical evaluation, here are some things that we're going to be going over. You'll see down below where it says screening for substance use and then questions and comments. We'll stop there briefly to see if there's any questions. And if there's time, then we'll move on to the DSM-5 and treatment options. Okay, first of all, you'll see here that the stages of a change model were developed by Prochaska and DiClemente. That was in 1980 with the work they were doing with cigarette smoking and treatment. It's also used to characterize other addictive disorders, including alcoholism. Here are the stages of readiness to change, pre-contemplation, all the way to determination or graduation. We'll get a little bit more into this in a little bit. With pre-contemplation, usually the client, they don't recognize a problem in their life. They don't see that their behavior is problematic. For instance, this could be someone that they could have been using substances for a while. To them, they're not having any problem. It's just part of like life, maybe. They haven't even thought of changing anything. So then they get into contemplation. Usually, when there's maybe a problem, they realize that their use has causing problems, and it could be at work, with family. It could be a number of reasons. But at that point, they're a little ambivalent to change. They may acknowledge that there may be a problem, but at this point, they're considering this change. But the ambivalence may come about, well, this is something that may have helped me in the past. One way to look at that is almost like a friend who you rely on when you're having problems. But eventually you find out that this friend, or whatever it is, really isn't in your best, isn't the best for you, maybe causing problems and you didn't realize it. So then we get into determination and preparation phase. And at this point, they're prepared to change. They're committed to that change. They have made a decision to change. So then they have seen what has been going on and they don't want it to happen anymore. So they're really looking at change, and then they get into action. They're actively involved in that change, and they're implementing a plan. Usually around here is when you'll usually see people enter treatment. A lot of times you'll see that with the earlier ones, especially with pre-contemplation, that they may be resistant to treatment. They'll tell you they don't have a problem, but through the counseling process, you'll see that some of the things they are saying aren't matching up to what's going on in their lifetime. So then after action, it becomes a maintenance with relapse cycles and recycle. Remembering that relapse does not have to happen though. They have a behavioral change. They may become confrontational with the level of new behaviors. And if you think about change, anyway, change is hard. I mean, if you're looking at even just vacations or marriage or divorce or anything like that, it's always a little bit more difficult. Could be ambivalence even from somebody going from eighth grade into high school. So then termination or graduation is when the change has become very stable. The problem behavior is either resolved or much better. This is something to look at because with with the stages here in between, it can mark a really difference between whether they're able to graduate from the program or whether they need more help with that. I know a lot of times with treatment centers and stuff like that, they have so many weeks and they're expected to be here at that point. But remembering that not everybody is going to go through the same growth and learning that others will. So this is something really to look at during this time. Okay, so facts about change. Remembering that change is a natural process. Um, Brief counseling can speed up the change process. Faith and hope are important elements. It helps to have other support. Counselors do matter. Empathy is not merely having had a similar experience. People engage in change talk and resistance talk. Now, one thing I always try to remember about change was that change can be very difficult. Um, there was kind of a little activity that I used to kind of go through, and it really helped. I'd even done it with professionals and stuff like that. Was you get out a piece of paper and you give everybody a pencil. It can be at the beginning of like maybe a group or something like that. You have this maybe a paragraph or something written on a board or whiteboard, and you have them write it down. Write down what is in that paragraph, but they have to use their non-dominant hand. So then over time, um, you're going to kind of rush them, saying, "I really need to get this into my supervisor because this is part of how he is evaluating my process and what I'm doing here in the group." So with this dominant hand, they start to write, but it's a lot slower. So then you kind of rush them at first, saying, "I really need you to finish this. I really have to take this to my supervisor right away." In the middle of this time, you tell them, "Look, I don't, however you want to finish it, just finish it. I really need to get this to my supervisor right away." And many people will then go to their dominant hand and finish it and give you the paper. After everybody's finished and giving you the paper, then you can let them know that this was kind of an activity that has to do with change. And that remembering that change is difficult for everybody. Usually, with change, it's a difficulty because you have been so used to using um, these things in your life to help you, coping skills or whatever it might be, but they have helped you in the past. And normally, when under pressure, when there's a lot of stress, they'll go back to what they knew worked for them before. So, this is something very important to remember, even with clients, because we ourselves go through the same kind of things. And remembering that it can be a way that we think, it can be the way that we behave, the way we feel. Maybe there's difficult feeling in the past or emotions that have to do with certain things. So they have learned to maybe get angry because they have learned that anger pushes these people away so they won't keep pressing. So remember, we all kind of have our own coping skills and things that we use. But I thought that's something very important to remember working with the clients is that change is difficult for everyone. Okay, with interviewing skills, there's micro counseling, motivation. It came from Alan E. Ivory, who was a distinguished university professor with the University of Massachusetts. You'll see micro counseling is an analysis of counseling skills that looks carefully and in great detail at the elements of the counseling relationship. Regardless of the aims and methods of counseling relationship, understanding its micro elements helps counselors improve their effectiveness. For instance, like building more rapport with the clients. Sometimes it's just these little details that will allow a client to elicit more information from, or the skills of the counselor can elicit more information from the client. So then, for instance, like attending, um, a counselor's interest in the client demonstrated by eye contact, body posture, and accurate verbal following. But remember, with this can be a little bit more different with Native Americans because you might not always get much eye contact. I mean, eye contact can be looked at in many ways. It can be something aggressive. So, in looking at eye contact with your client, especially who's a Native American, just because they're not looking doesn't mean they're not paying attention. So, try to keep that in mind. Attending behavior encourages the client to talk. Active listening, remembering that some of these sayings, how many people listen to reply instead of just listening to understand. And that's something to keep in mind. So a lot of times, if you're trying to understand what's going on in somebody's life, if you're really trying to understand the things that's going on in their lives, they may open up more. Even by just expressions on your body. It's very important to watch your body and not just what you say. Open-ended questions normally cannot be answered in a few words. It offers encouragement, and the client will speak more freely. These are questions that they can't just answer yes or no. So then close-ended questions are those they can usually just say yes or no, but it tends to turn the focus on the professional away from the client. So some of these questions might be, can you give me more information about that? Or that's very interesting. Tell me more. Things like that. So remember to use open-ended questions. One thing that I was always taught about counseling is that if you are talking more than the client, then you're not doing it correctly. The client should be talking more than we do. Client observation skills, remembering that nonverbal behavior is 85% of communication. Verbal behavior, maybe just using keywords. We're looking for discrepancies in the client's communication, whether there's mixed messages, they're saying two different things at the same time, but they don't quite mix. Contradictions, they might tell you something that has happened before, later on maybe in the evaluation or assessment, that contradicts what they said prior to that. So remember, there's things that are going to conflict. There are incongruencies in the way that they're speaking and telling you about certain things that are happening in their life. For instance, they may say that when I use, I never get in any arguments or anything like that. It's not causing me any problems. But then later on, you find out that maybe the spouse has been complaining about that, and they do get in some little arguments. So then this could be something that you can bring about, but try to do it respectfully. You don't really want to push the client away. Remember to encourage the client. Paraphrasing, maybe the client had gone and told you all these things or stories, or maybe a certain thing that happened, and you kind of put them together and repeat not exactly what the client says, but that allows the client to realize that you were listening to what was being said. Summarizing can be near the end, or sometimes people might use it in the middle, but it's always good to summarize at the end of a session so the client realizes that you heard everything within that session. But what you talked about, how things going on, and put the details in, things like that, that really allows the counter or the client to know that you were paying attention to the whole session. Okay, reflection of feelings. The client's feelings, either stated or implied, as expressed by the counselor. So the way that I can kind of think of this, and this is one reason I think that maybe more professionals need to be gone a little bit further, maybe into attending and what's going on to what the client are saying. So then if they're telling a story, sometimes to understand that, what you really do is you can almost imagine yourself going through this while they're telling the story. That allows you to maybe think about more. It's like, how would I feel if this happened to me? How would I feel when these people would say certain things about me? And when you're able to express those feelings that the client had during those times, it lets the client know that you understand what's going on. So remembering that even though we might not have the exact same experience in our lives, we're able to bring about these feelings and emotions are nonverbal. So then maybe they actually said they were sad. Maybe the way their body moved, you could tell that they were angry. Maybe they've clenched their fist. One thing to look at too is clients who rock are repetitive movements with their body. Sometimes they're a little, maybe they don't feel a little uneasy during that time. So that'll help you in assessing your client a little bit further. So reflection of meaning is finding the deeply held thoughts and feelings underlying this life experience. Paraphrase is to thoughts as reflection is to feeling. So it breaks down complex behavior into parts. So you're talking about this life experience and everything that they've gone through in their life. Maybe they don't see change something within us or to come to some kind of conclusion that'll help us in life. I mean, if it's kind of like goes back to some of the teachings I've been taught in the Native American teachings is that when we walk, when we decide to walk a certain road in our life, some may talk about this as like the red road or something like this, or a spiritual road, a path. We are to look at our past and ever as far back as we can remember. So then within this beforehand, we see all these themes coming up. Many times these will be like stepping stones in our life. So then we'll see these certain themes. For instance, youth, like maybe when they were really little, um, some kids used to, stick their tongue out at them or something. After a while, they came to conclude like this isn't helping me at all. It doesn't hurt. I can just ignore them. Well, maybe later on it comes to maybe they got pushed, and at first maybe they thought of it more as, oh, this was an accident. I don't have to worry about this. But later on it gets into shoving and more until maybe they eventually get in a fight or something. But you'll see as time goes on that these are stepping stones and helping us to evolve further in our own life and helping us to understand. So when you're an adult and somebody sticks your tongue out, it's more funny. You can see that this is just plain silly. I mean, this person's silly, but so things go on in life like that. So then when we come to this other path and we're going to make that decision to follow that path, we use our past to help us as kind of a map along that thing to see how we're going to learn even further. It helps you to realize that life is about learning, and that when you come to finding deeply held thoughts and feelings underlying life's experience, you'll see that what was taught long ago is pretty much true. That we're here to learn something in our life. That when we come to the conclusion that we are supposed to, then those things will stop. Okay, empathy, understanding what the client is experiencing and putting one, and that's one thing I was talking about before, is while this client is telling a story, if you can imagine your own self going through there and feeling those emotions and feelings and thoughts that are going along with it, it'll help you to understand what the client may have been going through at the time. Functions of empathy, it builds a firmer relationship with the client, enables the counselor to better understand. Common problems with conveying empathy is language and cultural differences between client and counselor. So, for instance, it's many times with the native languages and even other languages, it's hard to actually describe what it is in the English language because there's so much more meaning to sometimes in certain words. Cultural differences, remembering that what goes on, even like if somebody's going through grief, what needs to happen during that time. I think that's very important. That especially with since many of us work with Native Americans, we need to remember those things. Motivational interviewing. Many of you have already heard of a William R. Miller. You don't always hear about Stephen Rolnick. But William Miller originally developed motivational interviewing in an effort to increase the motivation of patients with alcohol problems to change behavior. As part of that process, Miller found that approaching patients with a modified client-centered approach increased the impact of the interview. What was evolved is a communication style and focus that increases patients' motivation to work on their problems. A lot of what people don't realize is, though, when William Miller was developing this motivational interviewing, at the time he was working with a Native American community, it was towards the Southwest area. And this is when he really began to realize the importance of communication with these Native Americans and how to help them even better. So then, that's something you don't really hear too much about how he developed motivational interviewing. Motivational interviewing. Um, Here's a book about it, the second edition, and it says on there, if motivational interviewing is a way of being with people, then its underlying spirit lies in understanding and experiencing the human nature that gives rise to that way of being. How one thinks about and understands the interview process, it is vitally important in shaping the interview. So I think that's very important to remember, um, especially as counselors, therapists, something like that in counseling or therapy. It's very important to remember these things because sometimes in how we say things, how we react, how we do things within that session can really shape how those sessions go. For instance, you might have heard that, working with certain clients, maybe they tend to get angry, maybe they tend to get very defensive. But remember, sometimes that's not just from the client. They are also could be what they are getting from their counselor as well. So sometimes working with a client who is getting angry and trying a little bit different way. For instance, you never argue with the client. You want to make sure that they feel they're being heard, not being judged or anything like that. I used to work with a lot of behavioral youth, and I know I was usually used the one to um, kind of lower down the anger and stuff like that was going on with the clients. And normally, what I do is um, pretty much what I learned from counseling youth and substance abuse anyway was I take them into a room. They could be ready to fight, they could be ready to just run off. But normally, what I did was to sit there with the client, um, let them calm down a little bit. If there was a little music there, maybe I'd put it on very lightly so it breaks up the silence. Because sometimes silence can also, um, that silence can be used to make them uncomfortable, so they'll talk more. But remembering that being uncomfortable can also make somebody who's angry be more angry. So, and I've always remembered that different sayings, how music calms even the savage beast. So I kind of remember those things, and I would play the music very lightly, let them calm down, and then I'd talk to them about, even the weather, different games or anything but what was going on in the office. And eventually they would calm down. And then after that, um, I would begin to talk to them about, well, what was going on back there? Why were you getting angry? And a lot of times it was, maybe they felt they weren't being heard. They were being rushed. They were trying to answer the question, but maybe somebody else got upset. But I think sometimes remembering some of these things in a session will really help. And that's one thing I've always tried to use. Um, Remember, motivational interviewing as a client-centered approach. It increases the client's response to screening and assessment and adherence to treatment. So it improves treatment outcomes by enhancing motivation to change. And that sometimes can be difficult with clients because, especially those who feel they don't have a problem, but maybe everybody else sees it, but they don't. So in helping them come to a realization that what they've been doing has many times been causing their own problems in life, it's important for them to remember and to realize. Clinicians commonly think that they are already practicing motivational interviewing when they screen, assess, and treat. What makes motivational interviewing a unique counseling approach is how skills are employed by clinicians. Motivational interviewing requires attention to timing issues, specific strategies, application methods, and maximizing the effectiveness of these skills. I think the timing can be very important to what's going on. If a client is getting to a certain point where you feel they're ready to say something, to encourage them at that time, just saying, oh, let's go back to here all of a sudden, and then you change it. So let those things come about. It's kind of like if you think about life, if you think about this communication that's going on, it's almost like a dance. So you want them to go one way, so then you move a certain way. I think that's kind of like more like life. Is sometimes things come at you, and in order to get around that, sometimes you just have to turn. The way that, like how wind blows, if you're very strongly forced and you're standing your ground, like the wind is just going to keep blowing at you. But if you become more rounded, in a sense, the air will become to go by you a little bit smoother. So remembering to try to keep your sessions as smooth as possible. Building motivation for reliable assessment and significant change. Remember your open-ended questions. Remember their affirmations, reflections, reflecting on feelings, summarizing, strengthening your commitment to change. Build on the client's motivation, resolve to change, sometimes called change talk. So, and when you're working on the client and their commitment to change, sometimes what we also remember to do is to compliment them in a job well done. Remembering that sometimes in looking forward, it's a little more scary. I mean, I think back in when I was in the military during this time, is that I remember we had to march a long ways and we had to go really fast. And I was carrying a lot of weight on my back. My feet hurt, my back hurts. I didn't know how much further I was going to be able to go, but I just kept going. And sometimes it was so difficult thinking about how much pain I was in. But what I remember to do is to keep my eye on the horizon, keep my eye forward and keep going. In the maybe towards the getting to the middle part, maybe it was very hard. But I thought about how much further I had to go. But later on, I began to realize I looked at how far I have already gone, and I didn't want to give up. I just wanted to keep going. And that's something like with life. We're going through something that's very difficult for us. Sometimes we just need to remember how far we've gone and how good that we did during that time. And sometimes that'll help us to look at going even further. So in the end, at the finish line, when you pass through that and you say, I made it, some people might say, oh, I'm so glad it's done. But you look back at what you went through and you realize what you did and what an accomplishment it was, not just to look at maybe more problems might come, because many times that's what happens is we go through things in our life that it seems so hard that we can't go anymore. But looking at what we've done already, we see the goodness in that. And many times we can look back and say, I'd do it again. So basic principles of motivational interviewing: express empathy, develop discrepancies, roll with resistance, support self-efficacy and optimism, avoid argument and direct confrontation. A lot of these are very important. If you look at self-efficacy, helping that person to be able to go on themselves, and being optimistic. So then, not to just see the negative things, but also see the goodness. I think that's something that's very important. The motivational interviewing fundamental approach is collaborating with your client, evoking more knowledge, and then being able to suggest autonomy. Remember, this person has autonomy. 4 principles is express empathy. Remember, not sympathy. Remember, there's a big difference there. So then developing these discrepancies, rolling with the resistance, support their own self-efficacy. Never to argue with your client. I think that's something, it's more or less like what we try to do is to help them see further into their self, not to just tell them how to do something. And I think that goes a lot really well with this last part, is when you're looking at people and they learn through their own life and be able to see how good they've done, how far they've gone, it helps a little bit, and let them know that they can keep going on and that they can make it. Brief interventions for alcohol problems. There are 6 common elements of brief intervention. You'll see that it uses the frames, but you'll see that F is for feedback of personal risk, and then responsibility of the patient, advice to change, menu of ways to reduce drinking, empathetic counseling style, and self-efficacy of the client or patient. So when I look at this, to me, I think of like a treatment plan, looking at the personal risk and what could happen, the client's own responsibility to take control of their own treatment and what they want to do in life, to have these goals set out there and make mini goals so they can actually see a growth, and they can actually see that they're moving forward. Because if they can't see that, they think they're stuck. So then giving them that advice to change, menus of ways to reduce thinking, and this is going to be very important, like with under crises. What else can they do? Is there somebody they can call? Is there somebody they can talk to? Is there something they can do? Whether go for a walk, remembering that cravings only last like 15 to 20 minutes, so that if they can get through that time, they'll be okay. Differences between screening and assessment. You'll see that through this, as time goes on, the more extensive information you're getting from the client, but also the knowledge that is being brought about, and what you're seeing is going to be more and more. So then with the screening, you might go just through a little bit. Through a diagnostic assessment, you're going to get a lot more information. Personal evaluation, treatment planning, you're definitely going to get through there. And remembering to use the client's strengths So a lot of times we think of strength-based things, what they're doing in their life that is really good that's going to help them. You know, can they go to sweat lodges? Can they go to ceremonies? Can they smudge each day? Different things like that that they can actually do on their own. A lot of times those are going to help them because it might be not things that we can offer, but and I know that many programs do, but it's something that they have as a strength to help them during those times. Screening is designed to reflect likelihood of presence of substance abuse or use today. Assessment is designed to provide a broader range of information on degree, kind, causes for, and possible treatments of the use. Remembering that screening doesn't always move to assessment or evaluation and treatment. Screening instruments, they're typically brief, normally require yes or no answers, can be administered by non-experts, and are obvious to their intent. So, and then assessment instruments, they generally are more time consuming, can require more complex historical based information, benefit from use by experienced examiners, and are not always obvious to intent. So maybe the screening instrument is helping you to understand whether this person is starting to have a problem or has a problem now. So then if they don't have a problem at all, um, maybe they might be discharged at the time. If there's something else that come up, maybe you're beginning to see this going a lot further. There can be things that, maybe there's some classes they need to take. Maybe they need some kind of drug and alcohol education classes or something like this. Um, Either that or it can go further into the assessment evaluation where you're going and getting a lot more information from them to benefit from them in order to gather information about their use, how it's causing problems, whether they have a family member, whether they're married, what tribe they're from, or whatever it might be. It's going to go further and further. Screening for substance abuse. Remember, today they have use. Identifying possible substance users is behavioral observation, observing the client. You might be able to tell if they've been using recently. Collateral information, eliciting information from friends and or relatives. Remember that though you had to have a release to talk with them. Laboratory tests, do laboratory tests reflect the problem. I really do believe in either UAs, also with the saliva tests. I really do believe in those a lot. It's something that if your program is willing to get, I think could be very beneficial. They can also be tested so you can get levels to see if they're going down. One thing that I always suggest with these tests is that don't just have a certain day you do them. You might want them to come out, just anytime. I've seen a lot of people, what they do is maybe do it every Friday. And what I had learned and seen during that time is that certain drugs don't always stay in your system that long. So some might only be like a couple days, 72 hours. So, and at times there might be clients who are still wanting to use and they'll use on the weekend. So sometimes what you'd want to do is hurry up and have one Monday morning, something like that. That way you're able to find out a little bit more what's going on in the test. Self-report, screening measures. We had the cage, the wraps, the mast, which is I think is used quite a bit. The taste and the tweak. You'll see here with the cage, it's used quite a bit. Um, a cut point of 1 detects about 90% of those alcohol-related disorders and 48% false positives. So then with cage, remembering in that cage, for the C, represents, have you felt you should cut down on your drinking? Have the client ever, has anybody ever been annoyed by criticizing your drinking? Have you ever felt bad or guilty about drinking? And the last one is, have you ever had an eye opener? So you see here with the wraps, um, during the last year, have you ever had feelings of guilt or remorse? Has a friend or family member ever told you about things that you didn't remember? So then be kind of like amnesia. Um, have you failed to do what was normally expected from you? So then the P was perform. And do you sometimes take a drink in the morning when you first get up or starter? And that's something that's very common with a lot of these tests, is that there's a lot of them that have either starters, eye openers, something like that. Do you feel you are a normal drinker? Do your wife, husband, or parent, somebody complain about your drinking? Again, the guiltiness, if you ever feel guilty. Do friends think you're a normal drinker? Are you able to stop drinking when you want to? Have you ever attended a meeting of AA? Has drinking ever created problems between you and your wife? This is something a little bit different, though. Um, Thinking about whether someone is a normal drinker or not, you might want to consider who you're speaking with, maybe the community members, because maybe around them when they're growing up, a normal drinker might be somebody who drinks a lot. Maybe they go on binges or something. Maybe to them that's normal. But remember, a normal drink is actually really, like casual drinking or something like that. Have you ever gotten into trouble at work because of using? You ever neglected your obligations? Ever sought out help? You ever been hospitalized because of your use? Have you ever been arrested or under the influence? Have you ever been arrested even for a few hours because of other drinking behavior? You'll see a lot of these have to do with the problems that are coming in their life because of their use. The taste, the T is for tolerance. Um, Anybody being annoyed? You ever felt you should cut down? Or again, the eye opener. You see a lot of these have a lot of the same things going on in questions in each of these little screening tools. Tweak is tolerance. Worried, eye opener, amnesia, and it's not on here, but there's for the K is if they felt they should cut down. Okay, look like we got to the point where we can have some questions. If there's any questions.
Great, thank you so much, Sean. If anyone has questions at this point, we'll just take a few minutes and take a break for just time to respond. So if you have questions, you'll want to type them into the Q&A pod, which is just to the right of the presentation, and we will respond to those as they come in. Thank you. Looks like maybe we can just move ahead for now, and then we do encourage you to submit any questions throughout the remainder of the webinar, and we will take time for those at the end. So thanks so much.
I think we have, what, 5 minutes?
We actually have until 1:30, so we got plenty of time left.
Okay. Okay, we'll move on. Okay, here we get into substance-related disorders in the DSM-5. You'll see here that they have includes 10 substance-related disorders. Moving on, almost all substance-related disorders in the DSM-5 include use, intoxication, and withdrawal. Almost all specify that the substance use disorder be rated either mild, moderate, or severe. Exceptions of those is caffeine use, hallucinogen, inhalant, and tobacco. Alcohol use disorders, alcohol-related disorders include alcohol use disorders, either mild, moderate, severe, alcohol intoxication, withdrawal, and other related disorders. The distinction between alcohol abuse and dependence has been eliminated in the DSM-5. You'll see that it's more like on a spectrum, where you'll see that if you have 2 or 3 symptoms are present, then it's a mild alcohol use disorder. Moderate is those with 4 to 5 symptoms. Severe are those with 6 or more. Are many of you already working and using the DSM-5 at this time? That'd be something to consider if you're still using the DSM-4. Okay. Alcohol use disorder is a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least 2 of 11 listed symptoms occurring with a 12-month period. So remember that it goes over a 12-month period. It's often taking alcohol in larger amounts or over a longer period than intended. A persistent desire or unsuccessful effort to cut down or control alcohol use. Spending a great deal of time in activities necessary to obtain alcohol use, or use alcohol, or recover from its effects. So you see that these are very common, very similar to the DSM-4. This is something new. The DSM-5 is they're bringing in cravings. And that's what they say is it's a strong desire, urge to use alcohol. Recurring alcohol use resulting in a failure to fulfill major role obligations at work, school, or at home. Almost made up a new word there. Okay. Continued alcohol use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. Important social, occupational, or recreational activities are given up or reduced because of the use. Recurrent alcohol use in situations in which it is physically haphazardous. Alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the use. Okay, with the tolerance, remember, and that's a need for markedly increased amounts of alcohol to achieve intoxication or the desired effect. Markedly diminished effect that continues use of the same amount of alcohol. The characteristic withdrawal syndrome for alcohol or closely related substance such as a benzodiazepine is taken to relieve or avoid withdrawal symptoms. You'll see here that the difference between alcohol use specifier change is the DSM-4 had physiological dependence specifier with physiological dependence or without physiological dependence. The DSM-5 has a severity specifier, either mild, moderate, or severe, and the patient status specifier is early remission, sustained remission, or controlled environment. So then, you know that the controlled environment is if they've been to treatment, if they were in jail or prison or somewhere where they couldn't use. DSM-4 specifier of with or without physiological dependence has been deleted from the DSM-5, and you'll see that with or without physiological dependence before it kind of went more like with psychological dependence or something like that. So then there was a difference between those. But with DSM-5, it's not there no more, or not the same anyway. Stages of change. Is there any questions or comments about these here? Okay, we'll move on. Treatment options. So then some may go to detoxification, pharmacological maintenance, outpatient, extended or intensive, partial hospitalization, inpatient or residential, aftercare, or support groups. So, okay, evidence-based treatments for alcohol use. Remembering that they also use motivational enhancement therapy, cognitive behavioral coping skills therapy, the 12 steps, facilitation therapy, community reinforcement, behavior couples therapy, pharmacological treatments using the use of SSRIs or opiate antagonists. Um, Remembering there's also going to be some difference between like a Native American treatment center or those that are not. Remembering that with the 12 step, there's also a Native American 12 steps. One thing I've tried to always seen with in substance use is that there are some natives who don't want to use the 12 steps, but they might be a little more inclined to use the Native American 12 steps or even like a talking circle or something like that. When you start to bring up these things, they're a little bit more inclined to go through. What's really kind of strange is I recently found out some information about the 12 steps is that what really motivated Bill and Bob is when they were developing the 12 steps, they were looking at Native Americans, and that's why they used the concept of like spirituality, a higher power, and things like this. I thought that was pretty neat. It was a story that it was told some Native American man when they were seeing one of them being buried. There was a funeral, and the other was there, and he approached this Native American man and asked him if he knew him. He said no, but he'd always the 12 steps helped him. And he approached this Native American man. He told him the story about how they developed the 12 steps. So it's pretty interesting because so many of the natives will say, well, that's not ours. That's not our way. It doesn't work for us. But what they utilized was information from the natives to help others. So it's something I think that they should be proud about and not just look at the differences of who normally uses them. Motivational interviewing heightens motivation to stop abusive drinking by providing patient objective feedback on its likely impact on health and quality of life. Cognitive behavioral coping skills therapy is identifies situations that represent substantial risk for continued abusive drinking, then helps develop both the skills to cope with those risky situations and the self-efficacy to believe that changes in drinking can actually be made successful. I really do. Um, I really believe in using coping skills with clients. It's something that you they can develop reasons. Like for instance, if they were to go out with their friends and their friends say, "Hey, let's do this or that. Let's have a good time. This is, I'll never ask you again," or whatever it might be. But it's good that they have an answer right away, because right away then they can say no because of this or that. And one thing that always comes up with this is in the assessments to ask you normally with youth is how many friends do you have? It might say 50. And it says, well, how many close friends do you have? And they'll say all of them. And I think it's a different kind of concept, I believe, because to me, when I think of really close friends, I think of kind of like in the military or something like that, with people who actually have your back no matter what happens, even when you're in trouble or anything like that. And the way I've been taught and the way I believe is um, people are lucky to find one real, genuine friend that would have your back your whole life, anything. It'd be they'd be lucky to find one in their whole life. And I really began to look at that. There was a medicine man told me that one time, and I hadn't understood it as much until he told me that. There was all these different teachings that went along with it, but it was really interesting because um, it really hit home for me. And then I believe that coping skills are something really good, especially during treatment, the beginning of treatment. I think as time goes on into aftercare, they're going to need that again. So it's not just something that is going to be used during treatment or um, even just aftercare, but it's something that they can remember to use all across the board. The 12-step facilitation therapy prepares alcoholics to benefit from the rigors of involvement with Alcoholics Anonymous. Community reinforcement approach provides alcoholics access to community resources and personal reinforcers contingent on maintenance of sobriety and other prescribed behavioral changes. Now, this is something that we should all be looking for. Work with Native Americans is finding access or finding these people in the community that can help them. Whether these are spiritual leaders, whether these are elders, whether they have certain programs within the tribe that can assist them. This is something that we should really look at, because normally what happens um, with substance use, what they always say with Native Americans is that the spiritual aspect is the first one to go. After that is community. And then after that is usually when they tend to have grief because of all the things that they used or things that they've done that or they've lost in their life. Because if you look at somebody, like maybe they were really going to ceremonies a lot, maybe they were really participating in a lot of things with elders and out in the open. But when they began to use, it's like normally what happens is because of the way that Native Americans are usually taught is you don't go to a ceremony or these functions while you're using. So they stay away during that time. When they do come back, maybe later, some of the people say, "Hey, where have you been? We haven't seen you for a while. What have you been doing, or whatever it might be." But they begin to kind of shy away from that because they're kind of worried. And later on, it gets further into community where they're starting to isolate themselves even further and further, and then even from their family and friends. Um, so later on, they have all this grief going on. So it's something that really needs to be looked at to bring more of the community back in, more of the family and different things like that to help them get back in the community and back on track. Behavioral couples therapy addresses both abusive drinking by the alcoholic spouse and the associated um, troubled couple troubled couple interactions that often accompany abusive spousal drinking. I really do believe that the spouse of the person using, the family, or children at least get some kind of education about what's going on. I think that'll help them and understand that they're not alone, but also help them to understand about change and that change is going to be difficult because many times you see, families or something, they may have liked um, a parent or something like that, a spouse when they used before because got so used to that. But with this change, it causes more stress upon them. So sometimes they want this old person back, and so they kind of may end up sabotaging the person trying to recover to begin with. Evidence-based pharmacological treatments for alcohol abuse, SSRIs lead to short-term reduction in alcohol consumption in alcohol-dependent individuals suffering from depression, reduce cravings following detoxification, and thereby increase likelihood of stable abstinence. I know that with Native Americans, they don't always like to take pills, don't always like to take certain things. I mean, um, they may they may tend to think, "Oh, well, I don't need those," or they may think that people are gonna think they're mentally ill or something because they're picking up these pills or something like that. But that's something that's been very common, I believe, with Native Americans. Um, one thing that comes to mind, though, is um, I've spoken to different medicine men before about this kind of things, and um, I used to see where maybe a person would be going to a doctor and they'd see a medicine man. Well, the person might tend to, well, I'm going to stop this medication and start using just what the doctor told me. But um, some of these medicine men would tell me, it's like, and tell them too, is to say, use this medication, but also use this medicine. After time, you may go off this medication, but that there should be handled by the doctors, and his medicine should be handled by him. So it's something that might help later on if you meet clients who don't want to use these. Um, one thing about medication is when somebody doesn't want to use, let them know that sometimes it can be like a crutch, helping them to get where they need to be so maybe they won't need this later. It's almost like somebody helping them along because for instance, when they're using this drugs and stuff to help them, it's the same kind of thing as using medication to help them. Great questions and discussion.
Thank you so much, Sean. It's great to be able to go through this, a lot of content to cover, so thank you for making it accessible and giving us some great examples. Yeah, we do have some time for questions, so please submit those in the Q&A pod at this time, and we will respond. While we're waiting for any questions to come in, I'll just remind everyone that we will be sending an email follow-up. For those of you who are with us, you will get a link to the recording of this webinar, as well as a link to the survey in case you are not redirected to it. You'll get a copy of the CEH request form and copies of the presentation handouts. And if you know others who registered but did not attend, they will also get a follow-up email, which will include a link to the recording and handouts. And then we'll just put up our upcoming webinars again for you to take a look at. And doesn't look like we have any questions at this point. So Sean, did you have any final thoughts you wanted to share before we close out?
I'd just like to thank everybody for listening in on this. If any of you are looking forward to are going to go for certification and licensure exams, say good luck. I wish you all the best. Thank you.
Great, thank you so much. And yeah, I'll just repeat thanks for taking the time to join us today, and we hope that this was valuable and helpful for you. So with that, we will go ahead and end, and hope you'll join us next time. Thanks so much.